Hi, my name is Mindy Christensen. Today I'll be speaking to you about fertility preservation for females with colorectal cancer. I have a couple disclosures. I will be talking for some time about brand name applications and off-label uses for non-FDA uses for medications. These include the use of GnRH analogs for ovarian protection. So objectives for today's talk are to help you identify patients who may be at risk for infertility after their treatment and who may be candidates for fertility preservation. Also, to compare fertility preservation treatment options and factors that may influence specific patient choice for those treatments. And third, to be familiar with future treatment interventions for fertility preservation. So the first question today is, what is fertility preservation? Fertility preservation is the process of saving or protecting eggs, sperm, or other reproductive tissue such as ovarian tissue so that in the future a person can use them to have biological children. Who can benefit? Well, obviously one group that can benefit would be patients who have cancer, especially colorectal cancer, who may be facing treatment that can be what we call gonatotoxic or harmful to the gonads, which can include the ovary as well as the testes. Also patients with medical conditions that would require treatment that could be harmful for fertility, such as lupus, and patients who have gynecologic conditions such as endometriosis or primary ovarian insufficiency. And finally, an important group today are those patients, especially women, who decide to electively delay childbearing, but want to cryopreserve eggs to keep that window open for the future. So one important thing to remember and to learn from this talk is that females are born with a set number of eggs. The highest number of eggs that a female will have is at 20 weeks gestation, a female will have 6 to 8 million eggs. At birth, that female will have 1 million eggs, and the number of eggs goes down over time. So if you look at the blue star on the graph, this would be a typical young woman, let's say an 18 to 20-year-old woman. She has about a little over 100,000 eggs. However, if she were to receive gonatotoxic treatment, such as chemotherapy or radiation, her egg supply will drop dramatically. She may not be menopausal at that time, but over the next 5 to 10 years, she may become what we call menopausal or lose her ovarian reserve or egg supply. So that's where fertility preservation can come in. Fertility preservation can help freeze eggs or embryos or ovarian tissue for a young woman. And fertility preservation is important. The American Society of Clinical Oncology encourages healthy survivorship and has identified fertility preservation as a key part of survivorship and cancer care. This is just looking at our fertility center. As you can see, since the year 2000, over the last 20 years, the number of fertility preservation patients that we see annually has increased exponentially. We're now seeing several patients each week for fertility preservation, and about a third of those patients are pursuing some type of fertility preservation treatment. One important thing to also consider is that women today are delaying childbearing. If we look back in time, women were typically having their first child in their 20s, but today about half of all women with a college education will be over the age of 30 when they even think about having their first child. It's for this reason that elective oocyte cryopreservation or egg freezing is becoming more popular. So when we look at fertile women affected by cancer, cancer in reproductive age women accounts for about 10% of all new cancer diagnoses. This is about 100,000 new cases each year in the United States. For the colorectal group, this is actually a growing population of young people. When we look at the most common cancers in women who are in the age group of 15 years of age to 39 years of age, you can see that there is a wide number of cancers that affect these young women, with breast cancer being the most common. But colon cancer and rectal cancer is recognized as a growing type of cancer for this group. There are several fertility preservation options that can be offered to a female before she undergoes treatment that could be harmful for her fertility. This includes freezing embryos, freezing eggs, or what we call oocyte cryopreservation, ovarian tissue cryopreservation, which was considered experimental until very recently. There's also ovarian suppression with a class of drugs called GnRH analogs that I'll speak a little bit about. And there's also surgical techniques, and these surgical techniques can actually really benefit patients with colorectal cancer because it can move the ovaries out of the pelvis. So this type of surgery is called oophoropexy or ovarian transposition. There's also a new class of surgeries that actually helps protect the uterus from radiation. I'll talk a little bit about that as well. So the first question, how do gonatotoxic treatments such as chemotherapy harm the ovary and therefore the egg supply? Well, as most of you know, chemotherapy will impact on rapidly dividing cells. And so what that means for the eggs is it mildly decreases the number of what we call primordial follicles, or very immature young eggs. And the larger follicles where eggs grow are also very greatly damaged. So the effects of chemotherapy on ovarian function actually vary widely depending on the age of the patient. The younger the patient, the lower the risk of having ovarian failure immediately after treatment. But it really also depends on the patient's egg supply. For instance, if you have a teenage patient who undergoes chemotherapy, her risk of what we call ovarian insufficiency or premature ovarian failure increases by a factor of 4. But for women between the ages of 21 and 25, that risk increases by a factor of 27. So the older your patient, the higher her chance of developing permanent ovarian failure. Classes of drugs that are most damaging to the ovaries include alkylating agents such as cyclophosphamide. They're the most damaging as they attack base pairs of DNA. But in general, there are many types of chemotherapy that are harmful to the ovaries. There are resources that you can use to look up to assess the patient's risk. Also, a reproductive endocrinologist could help counsel the patient regarding her personal risk. Radiation therapy is known to be even more damaging to the ovarian tissue and ovarian reserve than chemotherapy. The effect will again depend on the dose and the age and also the location of the chemotherapy. So for patients with colorectal cancer receiving radiation therapy, the ovaries can be at risk. For radiation therapy, the small primordial follicles where the majority of the eggs are stored are actually the most sensitive to being damaged and destroyed. So I'm first going to talk about embryo cryopreservation, which is the most established type of fertility preservation. Embryo cryopreservation has been around for over 30 years. So it's very widely established. In order to freeze embryos, the patient has to go through the process of what we call controlled ovarian hyperstimulation, meaning she needs to take injectable medications to help her ovaries make multiple eggs. She then undergoes an outpatient procedure called an oocyte retrieval, where the eggs are removed. And then in the lab, the eggs are fertilized, and then they can be cryopreserved or frozen at various stages of development. In general, embryos today are frozen at what's called the blastocyst stage, which is at day 5 or 6. Sometimes they're frozen at day 3, but day 5 or 6 is the more popular choice today. In the future, the embryos can be thawed and transferred either into the patient's uterus when she's cleared to get pregnant, or with a gestational carrier. Pregnancy rates of success with embryo cryopreservation really depend on the age of the patient at the time that the embryos were created. And pregnancy rates can be, range from 40 to 60% at the higher end per embryo transfer. In order to freeze embryos, the patient needs about 2 to 3 weeks to undergo the process to retrieve the eggs. So candidates for embryo cryopreservation are those that have a partner or are willing to use donor sperm. People who would not be candidates would be women who cannot delay their cancer treatment 2 to 3 weeks. Also, those who would not be candidates would be those without a partner or who decline the use of donor sperm, women who cannot delay treatment, children or minors, or those who have a moral or religious obligation to freezing embryos. In fact, there are certain countries where freezing embryos is actually illegal, so not allowed. Next, I'm going to move on to egg freezing or oocyte cryopreservation. So successful cryopreservation protocols or freezing protocols for embryos and sperm have been around for years, but freezing eggs has actually been much more challenging technically. That's because the egg is actually the largest cell in the human body, so it contains the most water, so it has very abundant cytoplasm, so ice crystals can form and actually during the freezing process damage the egg. The DNA or the meiotic spindle of the egg is actually the most sensitive to freezing. What also happens when we freeze eggs is that the outer rim of the egg, which is called the zona pellucida, actually hardens. What that means is that typical fertilization could not occur. A sperm could not penetrate the egg after it's been frozen. For this reason, the only way that we can fertilize eggs that have been frozen is through a technology called intracytoplasmic sperm injection, or ICSI, where we inject the sperm into the egg, which is what this picture depicts. There's two methods of freezing eggs. There's the conventional slow freezing method, which was first established, but the newer method of freezing eggs is called vitrification. Vitrification is a flash freezing of the eggs. It's a glass-like solidification that occurs. First, the eggs are exposed to a cryoprotectant that will help draw out the water, then they're flash frozen. The eggs themselves actually go from 25 degrees Celsius to minus 196 in 1 to 2 seconds, so very quickly. By doing this, this help prevents the formation of ice crystals. With the advent of vitrification, egg freezing has become very successful and very efficient, so much so that it's no longer considered experimental. It was announced in the year 2012 that egg freezing is no longer considered experimental, and because of that, its use has increased greatly. In order to freeze eggs, the patient will still require the same process as a woman who's freezing embryos, and that she'll have to undergo controlled ovarian hyperstimulation to have the eggs retrieved. So candidates for oocyte cryopreservation, the patient in general must be postmenarchal, meaning she needs to have started having menstrual cycles. I say in general because there have been a few cases in the literature of patients who were just about to start menses that they were able to retrieve eggs and freeze in those cases. But in general, the patient should have started having periods, and the patient needs to be able to delay her cancer treatment 2 to 3 weeks, which can be a challenge, especially if the patient is very sick. Those who would not be candidates would be those who cannot delay their treatment or prepubertal females. So vitrification is very efficient now that we're able to use this technology for freezing. Most of the data we have is actually from egg donors because there are a number of frozen egg banks available. So there was one meta-analysis that had 5 reports on vitrification that showed fertilization rates of 74% and clinical pregnancy rates of nearly 50%, with a live birth rate per transfer of about 37%. So very respectable pregnancy rates from frozen eggs. So as far as live birth follow-up, unfortunately, a central registry doesn't exist to follow the outcomes of babies born from frozen eggs. There is some data from live births worldwide that did show nearly 1,000 babies. There was no increased rate of congenital anomalies. Next, I'm going to talk about ovarian tissue cryopreservation, which is a newer technology for fertility preservation. So when we look at our main fertility preservation options, the 3 main options, there's freezing embryos, freezing eggs, and freezing ovarian tissue. The only option for prepubertal girls or for patients who cannot delay their treatment is ovarian tissue cryopreservation. So it is a fertility preservation method that enables the long-term storage of a significant number of primordial follicles, which are the most immature eggs that have potential to develop into mature eggs that are stored in the outside of the ovary called the ovarian cortex. Ovarian tissue freezing was considered experimental until very recently, December of 2019. And unfortunately, there's not a central registry to track babies born from ovarian tissue freezing, but there have been approximately 130 live births to date. So ovarian tissue involves harvesting of the tissue. It's generally harvested by laparoscopy, but it could also be harvested at laparotomy if the patient was having an open surgery. And the tissue can be harvested by either removing part of the ovary by biopsy or removing the entire ovary or performing an oophorectomy. Sometimes we can combine the procedure if the patient's having a port placed for chemotherapy under general anesthesia. But if the patient were having some type of colorectal surgery, that may be an opportunity to harvest the ovarian tissue at that time as well. And like I said, it relies on the freezing of the ovarian cortex, which harbors the primordial follicles. And these follicles are actually thought to be more resistant to cryo-injury than more mature follicles. There's 3 ways that ovarian tissue can be frozen or reported to be frozen. The most popular way is by freezing the ovarian tissue in strips or fragments. The ovarian tissue can also be frozen as the entire ovary, which is with its vascular pedicle, which has, for the most part, not been successful, and also freezing isolated follicles. Most of the data, the majority of the data in the literature, will involve freezing strips of ovarian cortex or fragments. And for ovarian tissue freezing, both slow freezing and vitrification are used. So in order to obtain eggs from frozen ovarian tissue, the method that's used currently is autografting, so transplanting the tissue back into the patient. Orthotopic transplantation is transplanting the tissue back into the patient's pelvis, and that's where the vast majority of live births have been reported. There's been reports of attempting to perform what's called a heterotopic transplantation, and that's when the ovarian tissue is transplanted into another location in the patient besides the pelvis, such as in the forearm. If we look at the timeline of ovarian tissue cryopreservation, it's a young technology. The first transplantation happened in the year 2000. The first live birth happened in the year 2004. And since that time, there's been at least 130 live births to date. And like I said before, it's no longer considered experimental by the American Society for Reproductive Medicine, and that was just recently announced in the last year. So this slide goes over the process of how ovarian tissue could be used. And so what this shows on the far left of the screen is the retrieval of one ovary. And typically that's what a lot of us are doing, is we're retrieving one ovary, harvesting one ovary. And then with that one ovary in the lab, we're dissecting off the ovarian cortex, where the majority of the eggs are stored, and then cutting them into little strips or cubes, and then the strips or cubes are frozen. In the future, it can be thawed and then transplanted back, generally into the patient's pelvis, and there's a variety of techniques to do that, which I'll go over in an upcoming slide. In this picture, you can actually see it's being transplanted into the existing ovary. So one ovary is removed, the other ovary remains in place. And so what we find is after we transplant the ovarian tissue, after 30 to 60 days, it starts to make hormones on its own after it develops its own vascular supply. Reports of hormone production are generally as high as over 90%. And the ovarian function resumes about 60 to 240 days post-transplant. We usually see it about 60 to 90 days. The duration of the ovarian function is going to depend on how much tissue is transplanted. It can last 4 to 5 years, but in some cases it's lasted up to 7 years. It really depends on the volume of ovarian follicles that are going to be in the tissue that's transplanted. So suggested criteria for freezing ovarian tissue would be age less than 35 years of age, because that's when the egg supply or ovarian reserve will be the highest. The patient has a realistic chance of surviving, and she has at least a 50% risk of developing premature ovarian insufficiency, so meaning she's at the highest risk of losing her ovarian function. There's various methods, like I mentioned, of transplanting the tissue back into the pelvis. Back in 2001, it was actually transplanted on a frame of Surgicel, a graft. It's also been grafted into little pockets in the peritoneum. Also transplanted into tunnels into the existing ovary, and even a robotic surgery approach has been reported. So I'm just going to briefly go over some of the transplantation. And so this is a scaffold with alloderm. And so in the lab, the ovarian tissue is just sutured onto the alloderm, and then that can be in this case, sutured into the existing ovary. This slide shows the ovarian tunneling technique, which is also very popular. So if you remove one ovary but keep one ovary, then the ovarian tissue can be placed in the existing ovary, which is, from an anatomic perspective, beneficial because births have been reported from both IVF as well as spontaneous pregnancies. And this shows the peritoneal pocket method as well, where if the patient doesn't have an existing ovary, a pocket can be made in the peritoneum to place the ovarian tissue. So when we look at the outcomes from ovarian tissue cryopreservation, they're actually pretty impressive for a new technology. There's been a couple of case series. One case series looked at women who had orthotopic implantation of the ovarian tissue, so it was transplanted back into their pelvis. That study reported a 33% pregnancy rate with a 25% live birth rate. And both assisted reproductive technologies such as IVF was used, as well as some patients conceived spontaneously. A second case series looked at 22 women who underwent orthotopic reimplantation. And in that study, there was a pregnancy rate of 41% and a live birth rate of 36%. It's also possible and very popular to combine the ovarian tissue transplantation with IVF, which makes sense as the patient will have limited use of the graft, time with the graft. And so to optimize things, IVF can be combined. So one study that was published in 2016 looked at 20 women who underwent ovarian tissue cryopreservation between the ages of 14 and 39. And all 20 of those patients underwent a mini laparotomy procedure in which the ovarian cortex strips were transplanted into tunnels into the existing ovary. The hormone production rate, normal hormone production rate of estradiol was 93%. And then 53% of patients conceived and 32% had live births. And finally, this is a meta-analysis that shows, that looked at all of the reported studies of ovarian tissue transplantation and showed a cumulative clinical pregnancy rate of about 57.5% and a live birth rate of 37.7%. In this study, the mean graft longevity was about 27 months, plus or minus a couple of years. So next, I'm going to move on briefly just to discuss GnRH analogs because there's question about whether these can be beneficial. So GnRH analogs include medications such as leuprolide acetate or Lupron, and what these medications do is they stop ovarian function temporarily. It's theorized that by doing this, that toxicity from chemotherapy can be reduced because the ovaries are less metabolically active. GnRH analogs will then, what they'll do is they'll diminish ovarian function. And since the effects are reversible, resumption of ovulation is possible when the chemotherapy and the GnRH therapies are discontinued. So how protective it can be against gonadal damage is still under investigation. I counsel patients that using a GnRH analog could be protective, but it really shouldn't replace the choice of using another fertility preservation option if they're able to do that. So there are a couple studies that were both in the breast cancer literature that looked at GnRH analogs. One was a randomized control trial of 178 patients with breast cancer that were randomized to receive chemotherapy alone or with the combination of a GnRH analog. And their endpoint that they looked at was the rate of early menopause 12 months after the last chemotherapy. What they found was that in the chemotherapy alone group, the rate of early menopause was about 26%, but in the GnRH analog group, the rate of early menopause was 9%. So that was assessed to be a significant difference. Then a second study also looked at breast cancer patients. These were premenopausal breast cancer patients. This was a larger study looking at 257 women, and their primary endpoint at this point was ovarian failure at 2 years. And they compared a GnRH analog group to a chemotherapy alone without GnRH analog. And what they found was that the ovarian failure rate in the patients who received the GnRH analog was 8% compared to 22% in the chemotherapy alone group. So finally, I'd like to talk a little bit about ovarian transposition as well as uterine fixation, because for patients with colorectal cancer, there actually really is an opportunity to use these surgical technologies to help preserve fertility. So ovarian transposition is also known sometimes as ovarian suspension or oophoropexy, and it protects the ovaries from radiation injury by transposing them out of the radiation field. As I discussed before, the oocytes or eggs are extremely sensitive to radiation. Just 16 gray of radiation can deplete the ovarian egg pool for a woman who's 20 years of age. And what this surgery does is it moves the ovary out of the radiation field while the vascular pedicle remains intact. So common diagnoses for patients that undergo ovarian transposition include those with rectal or anal cancer, those with cervical cancer, as well as those with pelvic lymphoma. So factors to consider when counseling a patient about ovarian transposition includes the patient's age, her ovarian reserve or her egg supply, her desire for pregnancy. If the patient has no desire for future fertility, she would not be a good candidate. Her personal preferences, as well as her medical diagnosis and her prognosis. Contraindications would be women who are already menopausal. And if you had a concern for an ovarian metastasis, you would not want to transpose that tissue out of the pelvis. So there are various ways that ovarian transposition can be used. It can be performed either unilaterally or bilaterally, so either one side or both sides. It can be combined with an ovarian tissue harvest. And so, for instance, one ovary could be removed for ovarian tissue harvest, for ovarian tissue cryopreservation, whereas the other ovary then could be transposed under the radiation field. And finally, the patient could undergo another type of fertility preservation, such as egg retrieval for embryo or oocyte cryopreservation. And then following that, the ovary could be transposed out of the pelvis. So there's various locations to transpose the ovaries. Contemporary procedures transpose them above the pelvic brim and as lateral as possible. So this can include the intra-abdominal paracolic gutters, anterior to the psoas muscles, and also the lower paracolic gutters. So in addition to the ovaries, it's also really important to remember that radiation can damage the uterus. So what happens to the uterus is that pelvic radiotherapy can decrease uterine volume. It can cause fibrosis of the myometrium or muscle of the uterus. It can compromise the vascular supply of the uterus, as well as cause damage to the endometrium, which is the inner lining of the uterus where the embryo implants. There have actually only been a few reports of live birth with the patient's own uterus after extensive pelvic radiation. And most of those patients are actually those with Hodgkin's lymphoma, in which the uterus is not in the field. So because it's been recognized that the uterus is at risk due to radiotherapy, there's been a couple of methods reported to actually move the uterus out of the radiation field. So in 2017, for instance, it was reported a technique which was quite aggressive of uterine fixation that involved laparoscopic transposition of the uterus and as well as the ovaries and fallopian tubes. So what happened was they performed surgically complete mobilization of the uterus and the gonadal vessels, and they positioned the uterus by even disconnecting the cervix from the vagina. They were able to mobilize the entire uterus so that the cervix was actually anastomosed to the fascia surrounding the umbilicus. So they completely moved the entire uterus out of the radiation field. Another method that's been reported is much simpler, and this can be done laparoscopically. But in 2018, it was reported that there's a simplified method of laparoscopic uterine fixation, and this can often be combined with an ovarian transposition procedure or an ovarian tissue harvesting, but basically just moving the uterus, transposing it to the anterior abdominal wall with resorbable sutures can, during the time of radiation, help move the uterus out. This is actually a picture. This is an MRI of the uterus before uterine fixation. So you can see this is actually a patient with rectal cancer, that the uterus was in target of the radiation therapy. And after fixation, so this is before fixation, you can see right there's the tumor, right there's the uterus, and after fixation, the uterus is much higher up above. So next, I'd like to talk a little bit about assisted reproductive technologies. So for those patients who are unable to undergo fertility preservation, there's still options to consider. So for instance, donor egg. So even if a patient, for whatever reason, is unable to undergo fertility preservation, she may still be able to carry a pregnancy using donor egg, as long as her uterus was not damaged from radiation therapy. So donor egg can be used for women whose egg supply is depleted. It's a proven approach with very high success rates. Some patients will choose a living donor, but also it's very popular today that people are actually purchasing eggs from frozen egg banks. So even if the patient ends up developing ovarian insufficiency after her treatment, she could still carry a pregnancy with the use of an egg donor. Gestational surrogacy is also an option that we talk about with patients regarding fertility preservation. These may be patients who undergo a hysterectomy or may be at risk if they were to carry a pregnancy, or if they have to have long-term cancer treatment. For patients who have radiation damage to their uterus due to their treatment, they may elect to use a gestational carrier as well. So in conclusion, the indications for fertility preservation may be for cancer, especially colorectal cancer, and sometimes there's social reasons involved as well. Fertility preservation treatments today include sperm cryopreservation, which I didn't talk about as we were focusing on females in this talk. But for females specifically, fertility preservation treatments include embryo, egg, as well as ovarian tissue cryopreservation. We also discussed surgical techniques that can help preserve fertility. The most important take-home message from this talk should be that early referral is key. If you have a patient that you think is interested in fertility preservation, most centers will see these patients within 1 to 2 business days because it's recognized that it's very important to start treatment. And these are some patient resources that we use for patients. Fertile Hope and Live Strong are 2 sources that can be very helpful. So thank you very much for your attention today. I look forward to any questions that you have. Hi there. Thank you so much for your attention this afternoon, and thank you for having me at this conference. It's very exciting to be part of this virtual conference and talking about something I'm very passionate about, which is fertility preservation. There's a couple of questions that have come through that I'd like to address. One question was, what would you recommend to patients about advocating for their fertility planning early in treatment? I'm so glad to have this presentation, but we hear from patients time and time again that their medical teams didn't talk to them about fertility preservation. And unfortunately, what was described in this question is actually very common. Unfortunately, many patients are not offered fertility preservation. When a patient has a cancer diagnosis, obviously having treatment as soon as possible and having a treatment plan is very important. But the American Society for Clinical Oncology and other organizations have recognized fertility as a key survivorship issue, so it is really important. So obviously, this has been looked at a lot in the literature. You know, one thing is to make surgeons and oncologists more aware about fertility preservation. And I have to say that at many institutions, there's definitely a focus on fertility preservation, and also for the patients. It's not wrong for the patients to ask about fertility preservation and to ask about having a consultation with the fertility specialist. So I think it's, you know, the patient should advocate for him or herself, but we're trying really hard to educate oncologists and surgeons about fertility preservation and the options that are available. So thank you for that great question. Can issues of intimacy satisfaction be addressed? Well, that is definitely also a very important issue. So in addition to fertility after cancer treatment, intimacy and sexual health are also important issues, both for males and females. For females, many females may be okay with not having fertility, but they're not prepared for the consequences of early menopause or early ovarian insufficiency. And so that can result in menopausal symptoms for women, such as vaginal dryness. It can affect libido and other issues. And so it's really important for women, if they're having these issues, to speak to their gynecologist about treatments that can help. So those treatments may include hormone therapy or lubricants. And so that is actually another very important survivorship issue. And so women who are having those issues should be encouraged to speak to their gynecologist. And what do I think are the biggest barriers to addressing these issues? Well, I think there's several barriers, and this has been looked at a lot about barriers to fertility preservation. So those issues include insurance coverage. There's only a handful of states in the United States that have state mandates for fertility preservation coverage. And so in those states, females who are facing gonatotoxic treatment, such as radiation and chemotherapy, will have their insurance cover it. But there's many states where that's not an issue. So patients in the midst of a cancer diagnosis and having to move forward with treatment as soon as possible have to figure out how to pay for that treatment. And the treatment costs thousands of dollars in most cases. So for instance, a cycle to freeze eggs would be $10,000 to $12,000. And ovarian tissue cryopreservation as well, if insurance didn't cover it, would be thousands of dollars. So that's one big barrier. Another barrier is just having enough time. And another issue is educating people about the fertility preservation options that are available. So those are the major issues that I see. I would also like to encourage people that if you have questions that come up after this talk, you can always send me a message. I'm happy to answer any questions that you have about fertility preservation. Here's another question. You might have mentioned this, but how long can eggs be frozen for? Well, actually, there's no time limit for how long eggs or embryos can be frozen. So we haven't been freezing eggs that long, but eggs can be frozen for at least 20 years. There's actually babies that have been born from embryos frozen over 12 or over 20 years. So there doesn't seem to be a time limit for freezing eggs or embryos or ovarian tissue or even sperm. So that should be reassuring for the younger patients. And the nice thing about fertility preservation, if you freeze your eggs when you're 20 years old, even if you wait until you're 40, your chance of pregnancy will be the same as a 20-year-old. So thank you for that excellent question. So as I was saying, if you have any questions, please feel free to reach out to me and send me a message. An excellent resource that I use for my patients is the Livestrong website. So Livestrong Fertility has a lot of resources for patients about fertility preservation and about the risks of their treatment specific to fertility in the future. So that's an excellent website. The Livestrong Foundation also provides financial assistance for patients who may be undergoing fertility preservation. So that's an excellent resource for people. Okay, I think we've answered all of the questions. So like I said, please feel free to reach out to me if you have any questions. Otherwise, thank you so much for your attention this afternoon.